Okay, thank you so much, Sarah. Bruce, you had a question?
Yeah, Sarah, thanks for the nice presentation. Did you look at the phenotypic features according to how you came to know that they had VEDS? In other words, cascade testing or incidental versus the diagnostic eval?
Sorry, so just so I understand your question, more of which features were noted that led to the testing?
No, you have a group of people who were discovered by cascade testing, and you have a group that were discovered because they were referred for evaluation due to features, presumptively. So I'm just wondering on severity of those for whom had cascade versus severity of those who were referred for actual evaluation.
For this particular project, we didn't focus on that. That is something going forward, though, that we're more interested as we increase our sample size and further investigate this to look more into.
Thanks, Shireen. Oh.
Hey, sorry, I was just having some issues. Do you think the overrepresentation of cardiac anomalies is related to referral patterns to the hospital where you are, being a referral center for those anomalies in general?
I think it's something certainly worth noting. Again, one concern that we had was just the potential for selection bias, given we are a larger hospital. And with that, we do have a large cohort, but many times only because, again, they have more severe features. And so that is certainly something worth noting. I think, again, given the fact they're more likely to be seen, that is certainly a concern.
Yeah, and I can add to that might be a bias of just diagnosis in childhood, right? That if they have congenital heart disease, they're more likely to be seen by a cardiologist and assessed in a specialty center. So great question.
Thank you.
Dr. Munoz-Mascara? Oh, she doesn't have a microphone. She said, thanks for the clear presentation. Were these children receiving any kind of treatment?
As far as medications go, I believe about 80% or so were on medications. Almost all of them were beta blockers. I believe the majority of those were carvedilol and labetalol. Other than that, they do have periodic imaging surveillance, which again, I'll go to a little bit more in that in the next talk. But that's to my knowledge, the primary therapies for them.
Perfect. And it looks like Dr. Ghali had the same question. Dr. Dietz?
That was a very nice talk. My question is how you're categorizing, for example, splice site mutations regarding high or low risk. There was a pretty high frequency of splice site mutations in your population, and they can have different outcomes. It could lead to in-frame exon skipping that would make a mutant protein and potentially be a dominant negative type of mutation, or it could lead to an out-of-frame splicing event leading to RNA decay and haploinsufficiency. I'm wondering if you might get greater clarity if some either functional testing was done or predictions were made regarding the likely consequence of different splice site mutations.
Yes, with that, the way we currently, given the low sample size, really did a more simplistic stratification of splice site variants. Now, again, this is a very early on analysis, and this is something certainly ongoing. With that, what we currently had, and it was simplistic, was really acceptor versus donor. But going forward, again, once we have a greater sample size, that is something we will keep in mind and look more into.
Yeah, how that's a wonderful idea. I think we didn't have, some of them are novel, some of the changes are novel, and some don't have clear prediction, but it'd be great. Maybe we could read that with you and Peter. So,
thank you.
Dr. Sideris?
Do you hear me? Yeah, I'm a pediatrician in Europe, in Netherlands, and we have a rare disease community. And we try to teach as many pediatricians to recognize children with rare disease in general practice. Are there any recommendations?
Sorry, can you repeat the question one more time? Just so
she said, how would you recommend to pediatricians to recognize this condition?
Well, one of the things, again, from a pediatric standpoint, is really to, for one, assess the early history. Again, looking at a lot of the patients within our small cohort, a lot of the subjects come with hematologic issues, orthopedic concerns, as well as if they have a concerning family history, for example, with mom, there could be risk factors identified even as early as birth. Regarding the phenotypic features and the things noted on physical exam, again, based on our findings alone, and sort of just what's in the literature, really the hallmark characteristics of things that at least lead to concern for vascular Ehlers-Danlos, again, would be the prominent eyes, the translucent skin, potentially thin nose, pronounced eyes, things of that nature. So with that, again, once I think we have a little bit more information as to how prevalent these are, on a more general basis, hopefully some clarity can come in terms of what clinicians can use. But those are the kind of the findings from our study.
If I could make a comment, this is Peter. Elizabeth, nice to see you. Wonderful question to ask. I think one of the things that really is striking in terms of looking at what happens and how children might have been identified after these events is the almost universal presence of easy bruising. And it's easy bruising that doesn't yield to diagnostic findings. So they don't have identified platelet disorders, they don't have identified clotting factor disorders, and they don't have von Willebrand's disease. And so all of the things that would ordinarily be done, if there's unexplained bruising that is considerably out of the ordinary and is seen in places on the body that you don't expect to have them, that should really be one of the things that pushes there. And I think, as Sarah said, other things, that in the presence of club foot are often the kinds of things that get people to diagnoses. I think the facial features are more difficult in children. Some are very striking, and there's no question about it. But I think it's the ones that are being missed are the ones that have much less prominent features.
The translucent skin as well, Peter, wouldn't you, especially in kids, wouldn't you say?
I think if it's present, yes, but I think it's often not.
Thank you, guys.
Thank you, Dr. Fryer.
We like really typical features because it's 6,000 rare diseases and then thin lips. It's not very easy. Also, bruising, it's more likely to be child abuse. So in the people who know about child abuse, they should be educated on these conditions like osteogenesis imperfecta and bruising, because they may go to court. Parents may go to court because of it.
At least 4 of our families have been reported to CPS. Yeah. So I think we're going to go ahead and just move on for the sake of time. We can continue the discussion in the chat box. There were some additional questions for Sarah, and Sarah actually has the next presentation as well. Thank you, Sarah. Hal, did you want to start?
Yeah, that was a great talk. My question is, do you consider the presence and severity of vertebral tortuosity a general marker of overall disease severity, a specific marker of vascular disease severity, or potentially even a driver of vascular disease?
Shane, would you?
Sure. I'm happy to address that. So I think it was a big question in the beginning, I think, of whether it was a driver. And I personally don't think it's a driver because we see it very early. And I think it's more a biomarker that the arteries are getting affected as well. Reading a lot of MRIs, it's very rare to see this kind of arterial tortuosity. And so I don't know if it's, so far we've seen it in the TGF-beta related diseases and this disease, and also in Williams syndrome. And so I think it's more reflective of certain cardiovascular risk, not all cardiovascular risk, but I personally don't think it's the driver. We probably need more, but the adult population does start to think that if you have more tortuosity, you're more likely to dissect. But we're not seeing that even people with quite severe tortuosity, like in arterial tortuosity syndrome, they don't have dissections. So I think it's more reflective of disease.
So my, I guess an extension of my question is, you know, while I don't have nearly the experience you have in Marfan or Loeys-Dietz populations, you know, I can basically look at a kid from a general outward perspective and predict what their VTI is going to be. There's pretty good correlation between general disease severity and VTI. I'm just wondering, given your much greater in-depth experience, whether that is true or not.
I don't know if we've ever correlated that, but I certainly agree with you. But I think that the nice part of it, as for people who aren't as good at genotyping, like most cardiologists are terrible at phenotyping. I mean, most cardiologists are awful at phenotyping. Not people on this call, of course, but I think generally that's not something we're that strong at. And VTI allows a very objective measure of severity that's easier and then can be used in studies. But I do agree that it does seem to correlate.
Thank you.
Continuing on, Mary?
Yeah, this is great. I'm looking at the vertebral tortuosity, certainly for all of my patients. And what's been striking to me just recently is I'm seeing a lot more patients with iliac artery tortuosity, and also that external iliac and internal iliac branches, and could even be amenable better than just the iliac artery, I think, to characterization with the index like what you're doing with the vertebrals. I know Shireen's on this call too. I was wondering if you were correlating this, if you're looking at the pelvic area when you're also getting these images of the head and neck, chest.
Yes, we are. So right now, the way we're assessing it is for individuals that have chest, neck, and pelvic MRIs is then when we consider to have a complete scan, and that's when we can ascertain the VTI. So yes, that is something we're looking at.
I just comment really quickly, and Mary, to answer your question, in adults, there's not a ton of tortuosity in vascular EDS. You see it much more with Loeys-Dietz and Marfan syndrome. When I talk later today, I'll show pictures of what the iliacs look like in VEDS.
Yeah. And I think to just quickly comment on that, even in this population, you know, the median tortuosity in someone with Marfan syndrome is 20, and in VTI, and for Loeys-Dietz, it's 50. And in this group, it was, as Sarah showed, it was 9, which is normal. So the degree of tortuosity is significantly less than we see in others. But what's striking is that even with minimal tortuosity, we see increased risk, and it's not as apparent to the naked eye. So it's a little more concerning. I think we probably looks like we have to move on probably. Sarah, I don't know if you and I can respond to questions in the chat, but I want to make sure that we give everyone ample time to present. Thank you so much, Dr. Adam, for an excellent presentation. Dr. Shalhoub, did you have some questions?
Yes, thank you. I typed it in as well. I'm very interested in this idea of migraine headaches in people with vascular EDS. In my experience with them clinically, it seems to be correlated with the presence of these carotid or vertebral artery dissections, specifically of the skull base. So have you noticed that in your population? And especially this idea of also having TIA that's really a migraine with aura that looks like TIA, but it's not really a TIA. I'd love to know what your experience has been with those.
In fact, we assessed TIA only if there was a description of such symptoms by the patients and the presence of a dissection on imaging. It was a retrospective cohort, so we could not ask the patients about their symptoms, as some symptoms were very old. So this was mainly descriptive. But in fact, we have patients who can describe a headache or migraine, and then we find a cervical artery dissection, but we do not say this is a TIA. So the definition can be quite difficult. I agree with that. I don't know if I answered to your question.
That's very helpful. It's just, you know, the question is, I've been reading a lot about migraines, and apparently there's this whole class of migraines with aura that look very much like TIA. And so I'm beginning to wonder if this is what we're seeing in some patients.
We have,
go ahead.
Yes, sorry. We have some patients who have migraine with aura, and as we usually treat our patient with celiprolol, these patients have another beta blocker which is more efficient on migraine than celiprolol. So we have some patients who have real migraine, but no TIA.
It'd be great to learn more about this. You know, I have a young patient, I think he's only 7, who we thought was having migraines, but then they really are TIA-like symptoms, and we started on an aspirin and they stopped. And so it's just quite interesting. And he has a new neurologist who does think they're recurrent TIAs, even though he's never had a dissection that we can find. So, other questions? Oh, Dr. Shepard.
Thank you. So the issue that has been brought up, I think, which is we have a suspected proband with vascular Ehlers-Danlos syndrome. I want to be able to make a good diagnosis and hopefully intervene before the event that's going to make it easy to make a definitive diagnosis. Does that make sense? So I'm in a situation right now where I saw a patient on Monday who's 16 years old. She has a VUS in the collagen 3A1, head, neck, chest, abdomen, pelvis, MRA. The only finding, no tortuosity anywhere. Mild dilation of the upper cervical ICA bilateral.
This might be a sequela of dissection. If there is dilation of the carotid artery, so it is possible that your patient already had an event, but it is difficult to assess this as she has a variant of unknown significance. So we did not study the predictive factors which can lead to stroke or TIA, as most of our patients already had stroke or TIA before molecular diagnosis. So I understand your question, but it's quite difficult to predict the risk of your patient and to know when this patient will have such an event or if it will ever happen. It's quite rare, but if it happens, it might be a hint to say this is a really vascular EDS.
Well, so that's right where I was thinking too, is your data so valuable to me because I'm thinking, could this possibly be an early phenotype?
Possibly.
Thank you so much. It's so interesting that there's such significant prevalence of disease with such low symptomatology. Dr. Dietz and Dr. Junmacher were discussing in the chat section. I don't know, Hal, if you want to bring what you were talking up about alpha-1 antitrypsin.
Sure. So we have seen a few patients with vascular connective tissue disorders that have shown horrible early onset and rapidly progressive obstructive lung disease. They have been demonstrated to have alleles that should predispose to only mild or perhaps even subclinical alpha-1 antitrypsin deficiency, including heterozygosity for the S allele. Yet in this context of vascular connective tissue disorders, we're seeing profound obstructive lung disease at a young age. I'm wondering if you've typed any of your patients for the more common alpha-1 antitrypsin genotypes.
You mean if we look for that?
Yeah.
Yeah, we did not do. Maybe we should. The linear bands that we have seen in some of these patients have been reported in these alpha antitrypsin defects. So this is probably something we should have a look into. If more specifically, if we only have a small subset of patients to have these linear bands, but that is definitely one of the causes of these images, and maybe there's something to be looked at there.
Dr. Frank, given this significant prevalence, although you had an older population, do you think that routine CT screening of the lung should be employed, and how early?
Well, these examinations were not done for pulmonary purposes, for arterial monitoring. I don't know if it can be recommended to be done systematically in vascular EDS patients. And what would be the clinical interest for the patient to know that he has a paraseptal emphysema maybe that when he's a teenager, he's at a higher risk to have pneumothorax than other patients. It's difficult to tell. What is for sure is that there probably is a great fragility of the alveolar wall in patients, and it should be emphasized to patients to protect these against blast-like lesions. That's what the radiologist told me, that these defects they seen look the most like blast defects you see after an explosion. So that would be the main recommendation, I think, for young adults with vascular EDS is to protect themselves against that, if possible.
Yeah, it's interesting because at least in our practice, we mainly use MRI, not CT in young people, so we would not see a lot of that. Peter, did you have a question?
Are there concomitant pulmonary function abnormalities that go along with the CT study? The CT
yeah, yeah, that's our limitation. We don't have that dynamic control of the lung function, and because this is retrospective, so we don't have that data, and since our patients are non-symptomatic, they're not systematically tested for respiratory function. Of course, this would be something to be done in the future.
The high, I was, well, I'm never surprised by the high frequency of smoking in France, but it looks as if you may have people that are resistant.
It was current smoking and plus.
We cut out there.
Yeah, Xavier, I think you're not muted, or you are muted.
I'm sorry, I have some internet problems. I didn't hear anything in the last.
That may be the best. No, I was just wondering whether you think that there are some people who have vascular EDS who are particularly sensitive to smoking and others who are not.
I don't know. What is for sure is smoking is deleterious for the lungs, for anybody, and maybe especially, maybe also, and more certainly for patients with vascular EDS patients, because we didn't find any specific difference, but these patients are young. So if we don't discourage these patients from smoking, probably if we do a follow-up study over time, their evolutivity of these defects might be more severe given the toxicity of tobacco. So I think tobacco should be strongly discouraged, in seeing these defects on the lungs, strongly.
We try. Now people vape.
That's right.
Thinking that it's protective.
Well, thank you guys, everyone, for a great session. I think we're a little over time. Joe, did you have any announcements before we do a quick lunch break?
No further announcements, but we'll come back in another 30 minutes at 1:35, and we'll continue there. So thank you very much for participating. Now we'll put the recording on pause, and we'll see you in 30 minutes. Thank you.